We'll be breaking down all major concepts covered on the exam. Imagine an organ capable of being like 85% replaced by dead, fibrotic scar tissue, and yet it still functions perfectly enough to digest your lunch.
It's wild. The functional reserve of the human pancreas is just staggering.
It really is. But, that same resilience is exactly what makes diagnosing its slow, smoldering destruction one of the sneakiest challenges in clinical medicine. I'm Harvey, by the way.
And I'm Donna. We're MCCQE reviewers, and our entire mission here is to help Canadian medical students feel, well, just way more comfortable with the exam review process.
Right, and for this deep dive, we're tackling S04 GASTROENTEROLOgy. Specifically, we're focusing on a huge high-yield topic, chronic pancreatitis.
Yeah, the exam writers absolutely love testing the nuanced pathological traps of the pancreas. So our goal today is to make sure you navigate those tricky clinical vignettes without any hesitation.
Exactly. And just to be clear up front, all the educational material we're unpacking today is drawn directly from reliable StatPearls articles.
Oh, and a quick clinical disclaimer before we jump in. This deep dive is strictly for medical education purposes. It's not medical advice, right?
Yeah.
All clinical decisions require a qualified healthcare provider.
Perfect. So let's just define the baseline of what chronic pancreatitis actually is. Because, the first clinical trap often lies right there in the terminology itself.
Yeah, it really does. We're looking at a progressive inflammatory disease. And progressive is the key word there.
Right.
It's characterized by irreversible fibrotic damage to the pancreatic parenchyma. And that steady fibrosis, it just slowly wipes out both the exocrine and endocrine functions.
And that progression is literally where the first major exam trap is set. Because when a vignette mentions, like, pancreatic inflammation, your immediate instinct is to picture the acute presentation, right?
For sure. You
Right.
picture the patient writhing in the ER, clutching their abdomen.
Yeah. With that sudden severe pain radiating straight through to their back.
But the test writers, they completely rely on that reflex. They want you to conflate the chronic disease process with the acute one.
Which you just can't do.
No, you can't. Because histologically and clinically, they operate on totally different paradigms. In acute pancreatitis, you're dealing with this sudden, aggressive, inflammatory explosion.
Right, like under the microscope, the cellular picture is just dominated by a heavy infiltration of neutrophils.
Exactly, neutrophils. But when you look at chronic pancreatitis, the histology shifts completely. The tissue is dominated by mononuclear infiltrates. It's not an explosion. It's a slow, relentless, smoldering fire.
Right, and a smoldering fire doesn't always trigger the fire alarms right away.
No, it doesn't.
So clinically, that means the presentation isn't just this binary state of, being perfectly healthy versus having a sudden acute attack. Patients with the chronic form might just present with this unrelenting, dull, kind of insidious ache.
Yeah, and surprisingly, some patients can remain entirely asymptomatic for years.
Which is terrifying.
Right. While the fibrosis just silently creeps across the gland. They might suffer from breakthrough episodes of acute pain that land them in the ER, but the baseline reality of the disease is that constant low-grade fibrotic destruction.
Okay, so once that baseline destruction is established, the clinical reasoning naturally has to shift to the etiology. Like, why is this happening?
Right, and the epidemiological data provides a very clear demographic profile for the exam. The median age at diagnosis is 45.
Okay.
And looking at U.S. data, it affects Black individuals more frequently than white individuals.
Got it. And if we break it down by specific pathological triggers, excessive alcohol use emerges as the most common culprit overall, right?
Yeah.
And that presents predominantly in men.
Yeah, alcohol is huge. But hyperlipidemia is another major driver, and that presentation actually skews more toward women.
So the exam frequently tests those specific culprits. Alcohol and hyperlipidemia should be top of mind for you.
Yep.
But the differential has to stay broad, right? Because of things like ductal obstructions, so malignancies, gallstones, or trauma. And you've also got genetic and systemic drivers like cystic fibrosis, hereditary pancreatitis, and autoimmune diseases.
Yeah, CF is a big one to remember. But let's look closer at the most common etiology, alcohol use, because it reveals this really fascinating pathological paradox.
Okay, let's unpack this. Because the textbook mechanism is that alcohol stimulates the acinar cells to hypersecrete proteins, right?
Right. And then the fluid inside the pancreatic ducts becomes incredibly viscous. It basically turns into an immovable sludge.
Sludge, yeah.
And that sludging causes ductal obstruction, localized fibrosis, and then the acinar cells themselves start to atrophy.
Okay, but I have to push back on that mechanism just a bit based on the statistical reality in the sources.
Oh, about the prevalence.
Exactly.
Yeah.
If alcohol directly sludges up the pancreas and causes this obstruction, why do fewer than 10% of people with a documented alcohol use disorder actually develop chronic pancreatitis?
That's the paradox.
Right. I mean, if the mechanism was a simple one-to-one toxic effect, that prevalence should be exponentially higher. It just feels like there's a missing variable in the equation.
What's fascinating here is that the low percentage heavily suggests alcohol alone is rarely enough to trigger the complete fibrotic cascade.
Interesting.
Yeah, there have to be genetic and environmental cofactors aligning. And to explain this massive discrepancy, researchers have basically solidified two leading pathophysiological theories about how this destruction actually unfolds.
Okay, let me take a swing at the first one because the sources describe it essentially as a plumbing problem.
The plumbing problem, yes.
So the theory centers on an impairment in the pancreas's ability to secrete bicarbonate. Because in a healthy organ, bicarbonate acts as this high-volume flush, right, that washes the secreted pancreatic proteins through the ducts and right into the gut.
Exactly. It keeps things moving.
But if that bicarbonate flush is impaired, say, due to a mild CFTR genetic mutation, it simply can't keep up with the increased protein production triggered by the alcohol.
Right, and so the proteins just stagnate in those microscopic ductules. They aggregate and form literal protein plugs within the lobules and the ductal system.
And over time, those stagnant protein plugs undergo calcification.
They turn into stones. They solidify into stones, physically blocking the internal plumbing of the organ and trapping the digestive enzymes behind them.
Wow, okay, so that's the plumbing theory. But the second theory is honestly even more insidious because it happens on an intracellular level.
Yeah, the signaling breakdown.
Right. The damage occurs from the inside out through the intraparenchymal activation of digestive enzymes. Because we know the pancreas produces powerful zymogens, inactive enzymes.
Right.
And they are strictly designed to remain completely dormant until they reach the safety of the duodenum.
But recent cellular studies show that alcohol specifically diminishes the pancreatic cell's ability to respond to calcium signaling.
And calcium signaling is the fail-safe.
Right. Exactly. It's the vital regulatory mechanism that prevents premature enzyme activation. So when that signaling pathway breaks down, the fail-safes are bypassed.
So the digestive enzymes just activate while they're still packed inside the pancreatic acinar cells.
Yes, they begin actively digesting the pancreas itself. It initiates this vicious cycle of necrosis, inflammation, and eventual fibrotic scarring.
That is brutal. So whether the internal plumbing calcifies and backs up, or the calcium signaling fails and the organ literally eats itself, the end result is massive, irreversible scarring.
Irreversible is the key word.
Right. So when the zymogens are destroying the parenchyma from the inside out, what is the actual tipping point where the patient realizes, something is catastrophic?
Well, the symptoms are directly dictated by the specific functional capacity that's been destroyed. For the exam, the classic triad of symptoms you'll see in a vignette include prolonged abdominal pain, often punctuated by pain-free intervals, unintentional weight loss, and a very specific postural compensation.
Oh, the posture clue.
Yeah. The patient will frequently lean forward or even draw their knees tightly to their chest, and they do this to relieve the abdominal pain.
And that postural clue is massive for the MCCQE. Because leaning forward physically pulls the inflamed, heavy abdominal organs away from the retroperitoneum.
Exactly.
And that takes the pressure off the highly sensitive celiac nerve plexus where the pancreas is just sitting and throbbing.
It's a textbook presentation. But beyond the pain, the exam writers really want you to recognize the mechanical failure of the gland.
Right. I actually like to conceptualize the pancreas as a heavy manufacturing factory.
Okay, I like this.
It's basically slowly burning down from the inside. At first, the workers just shift to different assembly lines. The walls are charred, there's smoke everywhere, but the factory's still shipping out enough product to meet demand.
That analogy perfectly illustrates the concept of exocrine reserve, because the exocrine function is responsible for this massive output of lipase, amylose, and proteases required for digestion. Right. And when that functional reserve is finally exhausted, that's when the patient develops steatorrhea.
Steatorrhea. So we're talking greasy, foul-smelling, buoyant stools that are notoriously difficult to flush.
Yeah, because of the massive content of undigested dietary fat.
Okay, and here is a critical threshold for your exam prep.
Yeah.
The 90% rule. You have to remember this.
Oh, this is huge.
A patient does not develop steatorrhea or clinical pancreatic insufficiency when the gland is 20% scarred. or even 50% scarred. Steatorrhea only manifests when greater than 90% of the pancreatic parenchyma has been destroyed.
It's crazy. It just highlights how over-engineered the human pancreas actually is. You can lose 85% of your acinar cells to fibrotic scar tissue and still produce enough lipase to fully digest a high-fat meal.
Which is mind-blowing.
It is. By the time a patient presents in your clinic complaining of steatorrhea, you are looking at an organ that is functionally decimated.
Decimated. So if the exocrine factory is completely offline, what's happening to the endocrine output? Because the islets of Langerhans are embedded in that exact same tissue.
Right. And when that 90% threshold is crossed, the advancing fibrosis indiscriminately wipes out the alpha and beta cells alike.
Both of them.
Both. The destruction of those islet cells leads to severe glucose intolerance, which eventually cements a diagnosis of pancreatogenic diabetes. You'll frequently see this referred to on the MCCQE as type 3C diabetes.
Right, and type 3C is a completely different beast than type 1 or type 2.
Oh, entirely.
Because in type 1, you lose insulin production, but your alpha cells still produce glucagon to prevent severe hypoglycemia.
Right.
But in type 3C, the fibrotic scarring destroys everything. You lose the floor and the ceiling of glucose regulation.
That's a great way to put it. The patient has no insulin to lower their blood sugar and no glucagon to raise it.
So it results in incredibly brittle, volatile diabetes.
Extremely hard to manage. So navigating a patient who presents with unrelenting back pain relieved by leaning forward, significant weight loss, steatorrhea, and brittle type 3C diabetes, it requires precise diagnostic confirmation.
And this is exactly where the exam sets its most notorious traps. Because the evaluation of chronic pancreatitis follows a completely different algorithmic pathway than the acute disease.
It really does.
I mean, I remember my first time doing a practice block on this. I read a vignette about severe pancreatic pain, saw the word pancreatitis, and just immediately clicked check serum amylase and lipase levels as the next best diagnostic step. It just feels like the most logical reflex in the world.
Oh, they count on you doing that.
Yeah.
Selecting amylase and lipase for chronic pancreatitis vignette is a guaranteed way to lose points.
Yeah, learned that the hard way.
You have to remember the physiological reality of the burnt-down factor you mentioned earlier. In the chronic state, greater than 90% of the acinar cells are dead.
Right.
You cannot leak enzymes into the bloodstream if you don't have any functioning cells left to produce them.
Exactly.
So because of this profound glandular atrophy, amylase and lipase levels in chronic pancreatitis are frequently completely normal.
Normal amylase and normal lipase absolutely do not rule out chronic pancreatitis. The StatPearls literature is explicit on this front. Serum enzymes should never be considered diagnostic or prognostic for the chronic form of the disease.
Never. So, to confirm the functional failure of the organ, we have to evaluate the stool.
Right.
The historical gold standard for quantifying steatorrhea is the 72-hour quantitative fecal fat test. A lab value showing greater than 7 grams of fat per day confirms the diagnosis of pancreatic exocrine insufficiency.
But just think about the logistical nightmare of that test for a second. You are asking a patient to collect 3 entire days' worth of greasy, foul-smelling steatorrheic stool.
It's awful.
And they have to store it in their home refrigerator before transporting it to a lab. It is incredibly cumbersome, highly unpleasant, and compliance is, understandably, terrible.
Yeah, that logistical barrier is exactly why the single random fecal elastase 1 level has become the premier practical alternative.
Fecal elastase 1.
Yes. It requires only 1 random stool sample, and it's highly sensitive and specific. Elastase is an enzyme produced exclusively by the pancreas, and it passes through the gut without being degraded.
So a severely depressed fecal elastase 1 level provides definitive proof that the pancreas is failing to produce adequate exocrine output.
Exactly. Now, stool tests confirm the functional failure, but we still need to visualize the anatomical damage.
Right, because the literature always describes this chain of lakes appearance on imaging.
The chain of lakes, yes.
It represents the distorted, dilated ductal system pooling behind those calcified protein plugs we talked about.
Okay.
So what is the optimal modality for visualizing that specific pathology?
The premier imaging study is MRCP. That's magnetic resonance cholangiopancreatography.
Okay.
MRCP is not invasive, and it's highly sensitive for illuminating the hallmark calcifications, the overall glandular enlargement, and that classic chain of lakes ductal dilation.
Now, older attending physicians or, outdated study materials might still recommend ERCP endoscopic retrograde cholangiopancreatography as the initial imaging step.
Oh, yeah, they might.
But there has been a massive paradigm shift in the clinical guidelines regarding ERCP.
A huge shift. And it occurred because ERCP is inherently invasive. It requires threading a scope into the duodenum and injecting contrast dye retrograde under pressure directly into the pancreatic ducts.
Which sounds like a terrible idea for a damaged organ.
It is. Injecting pressurized fluid into an already damaged, inflamed ductal system carries a significant risk of triggering severe, acute post-ERCP pancreatitis.
Right. You do not want to subject an already suffering patient to an acute inflammatory explosion just to get an image.
Exactly. So today, ERCP is strictly reserved for therapeutic interventions.
Therapeutic only.
Right. If a patient has a severe ductal stricture or an obstructing stone that requires physical stenting or extraction, then you use ERCP. But for diagnosis, always select MRCP.
Okay, so recapping the traps. Normal lipase trap. Fecal elastase 1 for functional testing. MRCP over ERCP for diagnostic imaging.
Perfect.
So when the diagnosis is finally locked in, the clinical objective completely shifts. Because we can't reverse the fibrotic scarring, right?
No, the damage is done.
So the therapeutic goal becomes managing the intense symptoms, mitigating the malnutrition, and preventing lethal complications.
And the absolute cornerstone of management, like the single intervention that dictates the patient's long-term survival, is behavioral modification.
Right.
The patient must stop smoking, and complete abstinence from alcohol is totally non-negotiable.
Yeah, the mortality statistics surrounding continued alcohol use are just sobering. Patients who continue to drink alcohol after a diagnosis of chronic pancreatitis face a mortality rate 3 times higher than those who abstain.
3 times higher.
And furthermore, achieving total abstinence is one of the only reliable methods for securing meaningful pain relief in the early stages of the disease.
Absolutely. Now, once behavior is addressed, the focus has to shift to dietary restructuring. The exocrine factory is broken, meaning the gut cannot handle large, complex metabolic loads anymore.
So the diet must be transitioned to frequent, small meals.
Yes, and fat intake must be heavily restricted to under 20 grams per day to minimize the steatorrhea.
Under 20 grams is barely anything.
I know. But to offset the caloric deficit from that fat restriction, the meals are formulated to be exceptionally high in protein and carbohydrates.
But restricting dietary fat creates this secondary physiological crisis, doesn't it?
It sure does.
Because if the patient isn't eating fat and their pancreas isn't secreting the lipase required to break down what little fat they do eat, they rapidly develop severe malabsorption of the fat-soluble vitamins.
Right, vitamins A, D, E, and K. And the inability to absorb them leads to devastating systemic complications. We're talking severe osteoporosis from vitamin D deficiency and coagulopathies from vitamin K deficiency.
So dietary management must include aggressive, ongoing oral supplementation of these fat-soluble vitamins.
Absolutely. And we also provide exogenous pancreatic enzyme replacement therapy. These synthetic enzymes must be taken concurrently with every meal.
Right. They're effectively doing the chemical work the burnt-out pancreas can no longer perform.
Exactly.
Yeah.
But, even with total alcohol abstinence and optimal enzyme replacement, the pain associated with chronic pancreatitis can still be excruciating and unrelenting.
And formulating a pharmacological pain regimen for a chronic lifelong disease requires extreme caution.
It demands a very rigid, stepwise approach because the disease spans decades, right? So introducing opioid narcotics early basically guarantees tolerance, dependence, and worsening hyperalgesia.
Right.
The current guidelines mandate trailing a non-opioid regimen first.
And the specific medications utilized reveal the true nature of the pain. We aren't just giving them high-dose Tylenol.
No.
The guidelines recommend tricyclic antidepressants like amitriptyline, NSAIDs, and neuropathic modulators like pregabalin.
And we use TCAs and pregabalin because the pain isn't purely somatic.
Right. The chronic fibrotic inflammation actually envelops and damages the pancreatic nerve plexuses. It causes severe perineural inflammation.
So we are treating a visceral neuropathy, which is exactly why neuropathic pain modulators are so effective as first-line therapy.
But what happens when medical management and neuropathic modulators entirely fail to control the intractable pain?
Then surgical intervention becomes the final option, and procedures range from surgical decompression of the dilated ducts, like a Puesto procedure, to partial or total resection of the diseased pancreatic tissue.
Suggesting a pancreatectomy is a massive decision, though. I mean, the operative mortality rate for these resections can exceed 10%.
It's incredibly high risk.
Taking a patient to the OR for this disease carries a huge risk of death. And even if they survive, their quality of life is permanently altered by the complete absence of native pancreatic function.
Yeah, it really reflects the gravity of the overarching prognosis. The long-term outlook is heavily influenced by patient behavior, obviously. Continued drinking, ongoing tobacco use, and concurrent end-stage liver disease radically accelerate mortality.
What are the actual numbers?
Statistically, the 10-year survival rate sits around 70%. But as you track the disease out to 20 years, survival plummets to just 40 to 50%.
Wow. And throughout those decades, clinicians must maintain high vigilance for structural and systemic complications. The exam loves to test the downstream effects of this chronic inflammation.
I really do.
You have to monitor for the formation of pseudocysts, mechanical obstruction of the common bile duct or the duodenum due to fibrotic strictures, and splenic vein thrombosis.
Yeah, and you also have to aggressively screen for pseudoaneurysm formation in the surrounding vasculature. That carries a severe risk of catastrophic hemorrhage and demands immediate surgical or endovascular intervention.
But the most insidious complication is malignant transformation, isn't it?
Absolutely. Chronic pancreatitis places the patient at a profoundly increased risk of developing pancreatic carcinoma.
Right, because decades of unyielding cellular inflammation is a well-documented driver of genetic mutation in cancer.
Exactly.
Well, the sheer volume of high-yield pathology in this single disease process is immense. Let's just distill the most critical takeaways for the MCCQE so we have it all in one place.
One's good.
First, understand the pathophysiology. It's an irreversible fibrotic destruction, often driven by the complex interaction between alcohol use and failed calcium signaling, or impaired bicarbonate flushing.
Second, recognize the clinical presentation and the thresholds. The 90% destruction rule means you do not see steatorrhea until the glandular reserve is almost entirely eradicated.
Right.
And when the endocrine reserve falls, the patient develops volatile, brittle type 3C diabetes due to the total loss of both insulin and glucagon.
Third, memorize the diagnostic traps. Normal amylase and normal lipase do not rule out the disease because the acinar cells are already dead. Rely on fecal elastase 1 to confirm the functional exocrine failure and choose non-invasive MRCP over ERCP to visualize the ductal calcifications and avoid triggering acute post-procedural pancreatitis.
Perfect. And finally, master the management principles. Absolute abstinence from alcohol is literally a matter of life and death. Counteract the severe malnutrition with small, low-fat meals, fat-soluble vitamin supplementation, and synthetic digestive enzymes.
And treat the underlying paraneural inflammation with neuropathic pain modulators like TCAs or pregabalin before escalating to opioids.
Exactly. And maintain constant surveillance for lethal complications like pseudoaneurysms and pancreatic carcinoma.
Okay, so we've covered the etiology, the diagnostic pitfalls, and the comprehensive management strategy. But before we sign off, I really want to leave you with a conceptual puzzle that applies these rigid exam facts to the, fluid reality of human medicine.
I love this. Because we understand the localized destruction of the pancreas. But zoom out for a second and consider the cascading systemic fragility caused by this single organ's failure.
Right. You have a patient battling chronic, intractable neuropathic pain. They're suffering from severe cellular malnutrition due to exocrine failure. And they're managing incredibly brittle type 3C diabetes due to the simultaneous loss of insulin and glucagon.
This isn't a localized disease anymore. It is a total metabolic collapse.
Exactly. So how does that profound lack of physiological reserve change the way you, as their physician, must approach treating something as mundane as a seasonal flu or a minor urinary tract infection?
It changes everything.
Because when a patient's body is operating with zero metabolic safety net, a simple fever could trigger a catastrophic, life-threatening cascade. It fundamentally rewrites the math of clinical medicine.
It really does. The factory didn't just burn down. The supply lines sustaining the entire physiological city have been permanently severed.
Nice, beautifully put. Thank you so much for joining us on this deep dive. Keep up the phenomenal work in your exam prep, understanding the precise why behind these pathologies, avoiding the algorithmic traps, and recognizing the systemic consequences. That is exactly what is going to make you an exceptional clinician.